Mr. Garthwaite, I'd like to start with you. Tell me, what's your big picture analysis as to why we're seeing all this vertical integration in the healthcare sector? Specifically, what do you see as the main economic drivers and the main regulatory drivers for this type of integration? And are those drivers likely to lead to more integration of this sort in the future?
There are a variety of reasons why we're seeing this, so I can't give you sort of every possible one. A few things. One, we have seen United Health Group be very successful with a vertically integrated system. And so that's going to lead people to look at that and maybe see that that might be a model they want to imitate. The other is, and I talked about this in my oral testimony, that in time periods of uncertainty about the value creation process, where lots of firms have to make different investments in the value chain, you might be worried that you're going to make an investment today that doesn't prove to be profitable to you in the future, but might prove to be profitable to someone else in the chain. So I invest in retail clinics today, and in the future, the insurer is going to make money. In that type of uncertain world, and I think we're pretty sure that the world of healthcare right now is uncertain and evolving, in that type of world, you might end up seeing more vertical integration. I also think that we've seen a rise of specialty medications, and that's a more complex pharmaceutical product that's sometimes delivered in a physician-administered setting and covered by a medical benefit. Sometimes it's taken at home by a patient in a retail setting, and that would be covered by a PBM. And it's very hard to offer a coordinated benefit in those types of products, which are growing in their importance, if you have one firm that administers the medical benefit and one firm that administers the pharmaceutical benefit. So those are the types of reasons, I think, market-based reasons why we're seeing that. I don't think there are meaningful regulation-based reasons that are pushing this. I can't think of a set, well, if we just change this regulation, we would see less integration. I think instead this is a rational response by firms to try and adapt to an evolving marketplace.
And you think that exists separate and apart from the regulatory environment? In other words, your statement a second ago, even if we move to a different regulatory environment, you would still see a lot of this because of the nature of the thing itself.
I mean, it depends a bit what different regulatory environment you mean. If we went to one payer, single Medicare for all, that would be a different regulatory environment where you wouldn't see this probably.
Yeah, fair point, fair point. Dr. Capps, why are we seeing specifically a lot of the physician practices being acquired by healthcare systems? Is this does this represent an effort by physicians to want to be able to escape the regulatory requirements that place administrative burdens on them? Or how else would you explain it?
I think there are a lot of drivers. This is one that people have alluded to. This has been one area of vertical integration that has been shown in research I've written, but also a number of other researchers, to drive up prices. And when you look at specifically acquisitions of primary care physician groups by hospital systems, the patients under their care don't have lower medical spending and seem to have higher medical spending. So when you ask what the drivers are, it seems like there's at least potentially just a regular old profit motive in there, that somehow they're able, whether it's through lessened competition or exploitation of payment rules, able to make more money together than separately. So I would generally agree with Professor Garthwaite that regulations aren't driving much of the consolidation, but there are specific Medicare regulations that allow physician services to be paid more when billed through a hospital, and that can be one impetus to some of this integration. And I know CMS, MedPAC, and the committee perhaps are all thinking about that. So that's one specific driver. As to the administrative burden, I think when you think of a 1 or 2 or 3 doctor practice trying to run the business of negotiating with health plans and filing claims and all of that, you can outsource it. But in the modern era, that's harder, especially with electronic medical records. That just tells us the onesies and twosies maybe are inefficient and should be moving up to 10, 15, 20 doctors so they can do weekend hours and better and lower costs in the ER.
Regardless of whether they're acquired by a hospital, in other words. Just
exactly. Maybe the scale for medical practice has gone up. That could be true. It doesn't mean it has to happen through or with the hospital. One last thing to remember, Professor Scott Morton mentioned Kaiser. They are efficient. They do a good job, and they have integrated hospitals and physicians and the payment function together. So again, we can't just say, well, we can never have hospitals and physicians because you might kill the baby with the bathwater.
In your opinion, will further greater vertical integration throughout this industry end up being necessary to help move away from the fee-for-service model in order to help incentivize outcomes rather than just treating the symptoms?
Certainly. So if we take hospitals and physicians as one example, efficiency may require better preventive care to reduce inpatient admissions. If you expect hospitals to buy a medical group and then tell them to work hard to keep people out of the hospital, that's probably not going to work if the hospital is paid on a fee-for-service basis. If the hospital is actually paid based on the total cost of care for a set of patients under its purview, the population for which it manages, then they might actually do it. So you actually have to look at the payment mechanisms and the vertical integration together to ask which way it's going to go. One way you can get that incentive alignment is to add the payer function to the combination of the physicians and the hospital. But you can also do it through contract, and that's really what a lot of the accountable care organizations are attempting.
Professor Scott Morton, you want to comment on that same question? Whether or not whether or not greater vertical integration across the healthcare sector is going to end up being necessary in order to change the incentives?
I think what Dr. Kapp said is exactly right, that when you have a fee-for-service system, you're building in a financial incentive to overtreat. If you change that fee-for-service system to some kind of bundled payment or some kind of lump sum payment, then you're going to need all the entities required to treat the patient inside whoever's getting that lump sum, or the party getting the lump sum, the primary care doctor, has to have good contracts with the hospital or the rehab center to pay for the care that's needed. So it gets trickier, and I think in many ways putting entities that need to work closely together in a complex area like healthcare into one organization can work well.
It's the only way that those interests are aligned, I guess you might say.
It's a simple way to do it as opposed to writing a lot of contracts.
Right.